Good afternoon, everybody. Welcome to this Thursday lunchtime webcast. I'm told we have about 50 people with us online, joining us online, which is fantastic. You're all very welcome. The only thing I would like to ask people who are joining by webcast is that you mute your own microphones during the presentations. Thank you. I'm now going to introduce the panel. The first three representatives here on my right are from the WHO Treatment and Care Department. In the middle, Meg Doherty, the coordinator, Marco Vittoria, who is taking care of the adult population and work, and Martina Penazzato, who takes care of the pediatric work. Next to Meg, we have Heliasis Getahun, who is also from WHO, coordinating the TB, HIV and Community Engagement Department. Next to him is sitting Peter Gies from UNAIDS, the Director of Strategic Information and Evaluation Department. And next to him, Peter Godfrey Fawcett, who is the Senior Science Advisor at UNAIDS.
Great. So welcome, everybody, and nice to see many people joining in. As you know, we've had a number of joint knowledge seminars with the HIV department at WHO and UNAIDS, and I think it's a nice way that we can work together. And as all of you are aware, the conference on retroviruses and opportunistic infections is one of the major science meetings that happens in the US each year, and a number of us are lucky enough to be able to go and join in with various things at that meeting. So we think it's an opportunity just to feedback some of our perspectives. There's been a lot of talk going on the web and on various media sites. So you may have seen some of these things already. And in particular, I'm going to talk very briefly about PrEP because we have had a big meeting already here with WHO and UNAIDS on pre-exposure prophylaxis. And so I'm not going to talk a lot about it to leave time for some of the other areas that have come up for discussion. In UNAIDS, we've started talking about the pre-CROI and the post-CROI era of pre-exposure prophylaxis. Before CROI, these were really the studies that were out there. So in the top left, the IPREC study in men who have sex with men showed a 42% efficacy. And then in the TDF2 and the Partners PrEP study, in men who have sex with women and women who have sex with men, there was variable but quite good efficacy for preventing HIV amongst the HIV-negative partner. But unfortunately, there were also a couple of studies in women, the FemPrep and the VOICE study, that failed to show an effect of pre-exposure prophylaxis. And that was essentially because adherence wasn't good enough. So that was where we were standing before CROI. And then at CROI, there were three important big studies presented to do with pre-exposure prophylaxis. The EPAGAY study was a placebo-controlled trial which used PrEP on demand. So all the previous studies of PrEP, people have taken a tablet every day, whereas during EPAGAY, they took a tablet, 2 tablets before sex, 1 tablet after sex, and 1 tablet after that. And so it was sort of trying to find a more convenient way of dosing PrEP. And they found in this randomized placebo-controlled trial that it was 86% efficacious, so very effective at preventing HIV amongst gay men having sex with other men in Paris and in Canada as the prime sites. The PROUD study moved one step further forward still in the UK, in that there was no longer a placebo in the PROUD study. And that makes a big difference because it means that you then know that you're taking something that other people says works. And so it was still randomized, but what happened in PROUD was that people were randomized to either start taking their treatment immediately or to wait a year before they could get PrEP. So it was still a randomized design that still allowed a strong evidence base. And extraordinarily, it came up with exactly the same measure of efficacy. Again, 86% efficacy, very high efficacy. And then finally, the Partners PrEP demonstration project, which was done in Kenya and Uganda, this was not randomized. This was now a demonstration project, so no placebos. And it was using PrEP as a bridge in serodiscordant couples until the HIV-positive person had got started on antiretroviral treatment. So using PrEP for the period until the viral load was suppressed. About 45% of the time, the HIV negative person was taking PrEP and the HIV positive person wasn't yet taking antiretroviral treatment. So PrEP played a big part of the protective effect, and they found a massive 96% efficacy. So overall, these studies show an interesting finding that in men who have sex with men and in serodiscordant couples, these more real-world studies actually showed better efficacy than the more controlled clinical trials when people had placebos and didn't know what they were taking. And that's unusual in the world of clinical trials, for the effectiveness studies to be more effective than the efficacy studies. On the other hand, there was less good news from the FACTS 001 study that was looking at tenofovir gel in women in South Africa and unfortunately showed no effect at all in the overall big study population. And that was despite the fact that 50% of the women in the trial were indeed using the gel. If you looked at the people where there was clear evidence of tenofovir in the blood and evidence that they'd had sex recently, then you could see some efficacy. So it looks as though the gel is really not as effective as we would like, and certainly there are now 3 studies that have failed to show a strong effect of the gel. 2 studies that have failed to show an effect of the gel, the VOICE study and now the FACTS 001 study. Overall, we can see that it's straightforward to identify people who are at substantial risk of HIV, and that in the context of Europe and Canada and serodiscordant couples in the African study setting, it was also straightforward to use PrEP. Our challenge, though, is to increase the impact of PrEP, to find delivery systems that work, to increase adherence, and to bring down costs. And with that, I'd like to move on from PrEP. What we're going to do is we're going to have presentations from myself, Peter, and Hailey, and then we'll have an opportunity for some questions if people want to ask questions, and then we'll have the remaining 3 presentations. So let me now move on. If we can change the slides and change over to Peter's presentation. And if you've got questions out there on the webcast, please do send them in, and Susie or Celeste will bring them up so that we can read them out. Peter, over to you.
Thanks a lot, Peter. So I will just give you a brief overview of also aim to include viral load measurements at the national level again. So let me just quickly skip through these next 2 slides. They're cascades. This one is about female sex workers in Zimbabwe, just to show that it is possible to construct such a cascade at the national level. And again, to show that viral suppression is fairly good among the people that are on ART, but of course the proportion of people that are on ART is insufficient. And this next slide has similar cascades, but this time for MSM in 2 studies in Africa. One is on the left is from Togo and Burkina Faso, the one on the right is from Uganda. And so again, the viral suppression among the people that are taking ART is not too bad, in the order of about 80%. But the proportion of people that are on ART is actually quite low, and therefore overall the viral suppression in the whole population is like insufficient also. So let me then move to my final 2 slides. So this first one is about survival of people who have acquired HIV and who have seroconverted. And this is an analysis across 25 countries. It has aimed to bring together all of the seroconverted cohort data. And so what it shows is that survival, of course, is dependent on age, with younger people having better survival. But it also shows that survival in sub-Saharan Africa is very similar to survival in Europe and in North America, but the study also finds that survival is quite a bit shorter in Asia, in Asian studies. And so this data is important for modeling. We use it ourselves, and it is also available to other modelers. So then this is my last slide, and maybe I will just start by saying that you should have a look at it on the website, because it is quite complex, but it is a study that shows the evolution of life expectancy and how life expectancy has improved over time and specifically in the era of ART. The study investigates the gains that have been made in life expectancy in relation to time and also in relation to the advent of treatment. So let me just stop here. I know that I have taken a little bit more time than I should have. Thank you. And just to maybe close to say that a lot of these presentations, you can just find them on the CROI website as webcasts and follow the entire presentation. Thanks.
Thanks. Thanks, Peter, very much. And I'm sure that you took too much time because I ate into your time too much at the beginning. But we'll move straight on to Hailiezus, who's going to tell us some things about the TB-HIV highlights from CROI.
Thank you. So I'll try to keep the 7 minutes allotted for this presentation. So that's why we are providing the highlights. So I think the first highlight has been, as you know, one of the revolutionary things that happened in the last 6 years about TB diagnosis is the invention of the gene experts, the molecular tests that detect actually the DNA of the mycobacteria from in real-time PCR. And this gene expert is now recommended, and by WHO particularly, it benefits people living with HIV, and it doubles the capacity of diagnosis of TB in people living with HIV compared to microscopy. But still, when you see its performance for smear-negative sputum or smear-negative cases, it's only detect around 70%. So that means we're still losing patients, not able to diagnose. So these investigators, what they have done is actually really to look how they can improve the performance of the existing expert, and they call it ultra expert or expert ultra. So what they have done basically is they created a new cartridge that also facilitates, the amount of the sputum that is used, and also that doubles the purified DNA for the detection by the PCR. And under normal circumstances, the gene expert requires at least 50 colony-forming units per milliliter of sputum, but this new ultra only needs 5. So this is really an improvement by 10-fold. And also, when it compared the sensitivity for a smear positive, it's 100%. And for smear negative, it's 94%, which is basically equivalent to culture, liquid culture, which is really revolutionary. So this is still in the formative stage. So when it comes out and developed, I think it will really make a lot of progress and a lot of difference, especially for people living with HIV, where always TB diagnosis is difficult. And the next is really the utility of high-dose rifampicin, as part of the TB treatment. And the standard rifampicin recommended dosage is 10 milligram per kilogram, and this has been, studies based on studies in the 50s and 60s, and which is the current recommendation and standard practice. But there has been really studies to see its effectiveness with increased dose. And this study presented, by gradual increase of its dosage from, 20 up to 35 milligram per kilogram of weight. And the 35 milligram per kilogram of rifampicin was shown to be very well tolerated and increased the likelihood of improvement or, conversion of the culture in a shorter duration. And this is also a breakthrough to show that, by modifying the dosage of rifampicin, we can have better, treatment. The other one was a Temporano trial, which I understand, Meg will touch it later on. So this is a 4-arm study in Abidjan, which actually compared, early ART in the combination of isoniazid preventive therapy. So the key finding has been actually the both early ART and IPT really prevented HIV morbidity, and IPT alone was protective by 35%, which is really very good result particularly when we see now the reluctance and the skepticism of around implementing IPT. So this study will give a good base to push for the implementation of this intervention. But one thing which I would like to highlight is there is a really high completion rate of IPT, 94% in this study, which is, of course it's clinical trial, but I think we have to be very careful when we interpret it compared to programmatic implementation. And there is also a very low, loss at follow-up, which was less than 3%. The other key study presented was about drug resistance, particularly about XDR TB transmission in a South African setting. And what they found in this study, which actually followed patients prospectively, was that majority of the XDR was due to transmission. It was acquired, not necessarily due to failing or disrupting treatment in the past. And this actually shows also the importance of infection control for programmatic. And if we have good infection control practices, we could prevent the transmission of almost 80% of XDR in such settings. Similarly, when we look about the treatment of MDR and XDR, and this is a study that was presented from South Africa again, where they actually looked into the adverse events of treatment of drug resistance TB. As you can see in this graph, particularly hearing loss is really serious and very common. This is absolute, hearing loss. People become deaf. Is really high. It can go up to 60% of the patients, and up to 1 out of 425 are actually losing their hearing loss. Similarly, there is a high rate of renal failure, and you can see really the type of adverse events, including suicide, hypokalemia, hypoglycemia, and even anemia. So this is really shows the treatment we are using in drug resistant TB is really quite a serious issue. So in a nutshell, in a summary, what are the major points? The new expert ultra is a very exciting advance that can really change the way we practice TB diagnosis. And high dose rifampicin is more active to shorten conversion time for culture, and early ART and INH works. And of course, most XDR TB is transmitted, not acquired. And finally, MDR therapy is toxic, and we need to do more research really to improve this treatment. Thank you.
Thank you very much, Hailies, and thank you for keeping promptly to time. So now this is your opportunity to join the discussion. You've had a few comments from me about PrEP. You've had comments from Peter about HIV epidemiology, incidence, key populations, violence, stigma, and then you've had a nice summary from Hailies on TB HIV things. We're going to move to treatment after this short break for discussion. So if people have questions, please come up to the microphone so that we can ensure that people on the web can also hear the questions and hear the responses. So please form an orderly queue and come up if you'd like to ask any particular question. I'll kick off while we're just waiting for any of you to come up, and similarly, if there are any web questions, please go. Peter, I was interested to ask you about the incidence assays and whether they will be reliable enough to make comparisons across different settings. I'm aware that they're sort of, because they're slightly dependent on the ART and other things, will we be able to use them to look at incidence in very different geographical contexts?
Right, so maybe first of all to say that they will be used in different geographical contexts. One of the major issues with it is that they will require very large sample sizes, because if you think about typical sample size of a population-based survey, maybe it is around 10,000 or 20,000 participants, and so that derives prevalence estimates that have their uncertainty. And so the uncertainty that we get on the prevalence is like reasonable. Say if you have 5% prevalence, maybe the uncertainty bound will range from 4 to 6 or something, so it will be quite stable. But since we're trying to measure incidence with these assays, you need like 10 times the sample size to get the same precision. So while initially the people that are thinking about putting in place the national surveys that I talked about, initially the thought was that they could derive incidence estimates at subnational level. And so they've moved away from that idea generally because of sample size considerations. So we'll still have data that, say, compares Kenya to South Africa, but whether within Kenya we would have a lot of differentiation based on this incidence assay, it is like unlikely, but it could be, like it is possible with very large sample sizes, and it will also be more possible in the few countries that have very high prevalence and incidence.
And of course, most of the prevalence surveys have actually only aimed for national samples to begin with, so we've been going there. So please introduce yourselves, Annette and Carlos, to the people who are in the rest of the room and on the web. And have we got any questions coming in online that we need to pick up? Not yet. So Annette, please go ahead.
Thank you, Peter. I'm Annette Verster, in charge of key populations at WHO. I have two questions for you, Peter, as well. The first, and it has to do with baseline and data collection around key populations. The study that looked at the cascade data for sex workers in Zimbabwe, I was wondering if you know, maybe we have to go back to the study, but do you know whether these data were collected through programmatic data collection or through survey data? Because we know all the difficulties in having data on route of transmission in people, in patient registries, people on ART. So whether people are MSM or sex work usually is not reported. So I was wondering how this was collected. And likewise, the other issue, and it is with this baseline and estimation, the problems around size estimation, also the study on violence and rape, the percentages and everything. We know that rape generally is very underreported, so I was also wondering how that was collected and how it was used as represent kind of the percentage of the other data that you provided. Thank you.
Let's hold those questions and let Carlos ask as well, and then we can answer both questions afterwards.
Thank you, Peter. My name is Carlos Passarelli from UNAIDS. I don't know if I need to wait for the next presentations, but I was wondering during Peter Guy's presentation on the information that we had from CROI in relation to life expectancy and virus suppression, because we don't have the expected levels of virus suppression, but even so we have the good numbers in terms of life expectancy. So if you could comment on this, I would be very pleased. And I don't know if I'll be able to stay until the end of the meeting, so I'd like to make a suggestion. It was a very interesting presentation from on TB, so maybe we could have another session on other co-infections like hepatitis C and opportunistic infections as well.
Thanks. Carus, should we just fit your question? This is the last question, and then we'll let whoever needs to answer, and then we'll move to the second half.
Okay, great. My name is Carissa Kirago with UNAIDS, and I have a question for Peter Godfrey Fawcett about PrEP, and where you talked about that some of the trials were a person could take the medicine, the antiretrovirals, before sex, I think 2 pills before sex, and then once after, 1 pill after. And my question is, what about people who may have sex more than once a day? And how, if someone has three times a day, 4 times a day, how do they do that?
Okay, so let me try and answer the 3 questions that came to me. So the first is about the cascade that I showed for female sex workers in Zimbabwe. This was actually part of a plenary talk that was done by Francis Cohen. And so she explained, I think the work is unpublished, but if you want, you can find the presentation, of course, on the webcast of the CROI. But she explained that it's a combination of survey data among sex workers. And she also explained that, you know, this project, which is called the Sisters Project, it has like, I think about 14 like clinical sites across the country. And they estimate that that captures like a very large part of the entire population of sex workers in Zimbabwe. And then they've combined that data that comes from surveys, IBBS type of survey, with programmatic data that they also have in the clinics that serve the same population. So it's actually interesting because we have not, as you mentioned, had typically national level type information for key population. So I think it is an interesting avenue. And I also think that consortium that I mentioned will actually pick up on some of these ideas to try and take that further. Then your question about the study in Kenya about rape, my sense is that it is like a small area cohort study and research study in a very small area, right? So it is linked to a research clinic. To what extent there may have been underreporting of rape, I can't really assess that myself. But to me, it struck me that, you know, the level of, say, about 5% for both populations, that is just struck me as being quite high. And it was also interesting to see the exploration of the association with incidents. So let me move to the next question, which is from Carlos about life expectancy. So I didn't, having run out of time, I didn't explain a whole lot, but I think the data, it comes from the Alpha network, so it's population-based observation of entire populations over a long time period. So the one slide on or the image to the left of my slide is showing how overall life expectancy in that area has actually increased. And then if you look specifically at people living with HIV, life expectancy has increased by about 20 years over that long time span, while for the entire population has increased by about 10 years. And so ART plays a strong part in those changes. But for all of the study sites, it is also clear that there is still a gap. That is to say, we have not like completely caught up to get like the life expectancy of the overall population.
So let me just answer Carusa's question about on-demand PrEP and if people are having sex more frequently. And it's easy because what happens is that when you start taking on-demand PrEP, you then go on and you take a tablet the day after sex, or tablet after sex, and a tablet the following day. And if you have more sex, then effectively you go back onto the system as though you were taking PrEP continuously, just taking one tablet a day. So you never take more than one tablet a day, except for the very first time that you start. So if you haven't had sex for some time, you pop a couple of PrEP pills, then you can go out and have sex, and after that you take sex once every day. And if you only have sex once, you stop after 2 tablets. But if you go on having sex, you just take PrEP once a day continuously, which would then put you back in the same category as all the previous studies of PrEP. The good thing is that in the IPAGAY study, despite the fact that these were very sexually active men, they had less sex than perhaps you might have expected. So they actually used about half as much PrEP, half as many tablets as the people, for instance, in the IPREX study. So despite the fact that they were a high-risk group, so sometimes people say they have a lot of sex, but they're not having quite as much sex as they would like to think they were. Let us now move on to the second half of the presentations, when we will talk about some of the treatment issues. And I think Meg is, no, sorry, is Meg going to kick off? Yes. Sorry, Marco is going to kick off first.
Okay, thank you, Peter. Well, as commented here before, treatment optimization is really an important topic in always really focus in the CROI conferences. And then I try to bring my 7-minute picks in terms of optimization. Can you move the slide? You can move here. Thank you. Is the slide? You can move here. Well, this first slide is just to emphasize one of the major issues
having a negative serological test in these children doesn't mean cure, and that's something that we need to account for. Test in these children doesn't mean cure, and that's something that we need to account for. Test in these children doesn't mean cure.